So hi everybody, Shanta here. I have my presentation today. I decided to do it on pediatric obesity and sleep apnea. I had kind of a journey in arriving at this topic. My last presentation was on genetic disorders and pediatric sleep, and there were a lot of genetic disorders that I was finding were resulting in pediatric sleep apnea. And so I was going to do a special presentation on like special populations of pediatric OSA. But when I was looking at the data for pediatric obesity and OSA, I was actually finding a lot of interesting things, and that was only going to be like a portion of my study, but I ended up doing the whole thing on it. So hopefully you guys uh, learn something. I know it's not the most high yield topic for everybody, but it's still kind of interesting. So there were a couple of things I wanted to review. The mechanism of OSA in obese pediatric patients. There's not a lot of literature on really any of these topics, but I tried to find some nice studies that kind of outlined in like an evidence-based way a lot of these things. And then to review the current literature on treatment options for OSA in obese pediatric patients, and then also, is there a role for sleep medicine in addressing pediatric obesity? That's kind of the discussion I wanted to have at the end. I kind of wanted to start with a case. This situation hasn't really happened to me here at in Seattle, but it did kind of happen to me when I was in Cleveland in like my first sleep experience. But let's say you have a 7-year-old boy. He comes to you in pediatric sleep clinic with a referral from his PCP that he's, falling asleep in class and even missing a significant amount of school days. His other sleep symptoms are like snoring. Mother notices that he sleeps prone. He requires naps throughout the day. And then his vitals were stable. His BMI is in the 97th percentile, and he has a sleep study that's done. And you find that he has severe OSA. And you're kind of discussing treatment options with the mom, and you say obesity can contribute to obstructive sleep apnea in children, and ask if she's interested in like a nutrition referral. And she kind of becomes upset, and she says, every doctor just tells me the problem is his weight, and I'm tired of hearing about it. How would a nutritionist even help his sleep? There's got to be something else that we can do. And this was kind of a situation that did happen to me when I was in clinic in Cleveland, and it prompted me to kind of look into some of these studies because I think it's important to have like, evidence-based answers instead of just kind of relaying information from the adult world and applying it to pediatrics, because there were a lot of differences that actually kind of came up to my surprise. Um, so first, I kind of wanted to start talking about the prevalence of obesity in the United States. Back in the 1970s, 60s and 70s, only about 5% of children ages 2 to 9 were obese. And last year, according to the CDC, that was little over 22%, which is, more than 1 in 5 children. There is a racial disparity as well. 26% of Latino children, 25% of Black children and 16% of white children, with Asian children having the lowest prevalence at 9. There's an income disparity. 9.2% of youth in the highest income group are obese versus 24% in the lowest income group. And there's also a regional disparity with 7 states having much higher prevalence. It's like about a quarter of kids, and those mostly fall into like the southern states. And there's 11 states that have lower than national averages. And in Washington, it's 13%. So it's quite a bit lower than the national average. So, this is a super prevalent, sort of epidemic that's happening. And I think the kind of relevance for this topic today is that, 50% of obese children end up being obese adults. And so if that's something that we can kind of address, at this earlier stage, then that could be kind of helpful. And I included the BMI chart. It's a little bit different than it is for adults. Per age, you can kind of see there's a 5th percentile mark, an 85th percentile mark, and a 95th percentile mark. So for our little 7-year-old, his BMI kind of landed him like in the low 20s, which puts him above that 95th percentile line. And you can see the trends kind of graphically here. The top graph is from the CDC, shows in the 60s, the obesity rates was like around 5%, and you can see more recently in 2018, it's getting higher to the 20% range. And this was from JAMA last year, JAMA Peds, kind of a zoomed in version of the last few years. There's kind of an increasing prevalence that you can see for both girls and boys. And so, oops, I put these out of order. But there was one study that I looked at back in 2021. This was kind of a study that was looking into prevalence of obesity. It was a really extensive study. They used the Kids Inpatient Database in 2016 and looked at like around 6 million charts. And they looked at discharges. It had discharge information for children on a national level. And they kind of found that they separated it between children who had obesity and children who had OSA according to the ICD-9 codes. And they ended up with about 3,000 kids who had OSA, who were obese, and then about 32,000 kids who had OSA who were not obese, and they looked at prevalence rates. And so you can see that in those who were obese, the rate was about 106 per 1,000 discharges versus those who were not obese, it was about 5 out of 1,000 weighted discharges. And then they used a logistical regression model to kind of look at different independent factors that may have contributed to the diagnosis of OSA. They looked at like lymphoid tissue, gender, race, household income, regionality, and they even looked at insurance. And so among children with OSA, obesity was kind of associated with the female sex. Uh, and for ethnicity-wise, it was Black, Hispanic, and Native American that they found a higher association with, as well as median income of households making less than $43,000, and mostly in the southern region. And then for people who paid with Medicaid or self-pay, they ended up having higher rates of obesity as well. So I thought that was kind of an interesting, really like detailed and extensive study that they did. So we've kind of established prevalence, that data is, difficult to argue, and there's multiple kind of studies that support that as well. But the 3 other things I wanted to kind of look into was mechanism, correlation, and treatment. I was finding that a lot of the literature I saw kind of talked about the fact that a lot of what's known about pediatric obesity is kind of just assumed, from the adult world in terms of like upper airway collapse, um, chest wall excursion in obesity, and then treatment options as well. And so I kind of wanted to see independently what studies had been done, specifically in children who had obesity and OSA. So this first study is from Aaron's. This was mostly looking into mechanisms here. They looked into demographics, PSG findings, and correlation coefficients. The mechanism of pediatric OSA is actually kind of poorly understood. The assumption is that there's a presence of fat at the level of the pharyngeal soft tissues that kind of contributes to collapse and vulnerability of that airway. And then that presence of fat in the thoracic and abdominal walls that reduces respiratory function. But is that really the case? So they had some investigators look into this because the American Academy of Pediatrics, it does recommend adenotonsillectomy as the first treatment modality in obese children. But this study kind of wanted to look at exactly what mechanisms they were finding that were associated with OSA to see if that would be kind of the first line treatment option. And so that's kind of where the study came from. So the methods that they used magnetic resonance imaging to determine the size of upper airway structure and body fat composition. Then they used paired analysis and logistical regression models to determine whether the BMI Z score was actually a modifier for these anatomical characteristics as it relates to OSA. So what they found was they looked at 22 obese subjects with OSA and 22 control subjects. Compared to the control subjects, the subjects with OSA had smaller oropharynx, larger adenoids, tonsils, and retropharyngeal nodes. And so the size of the lymphoid tissues did correlate with the severity of OSA, whereas the BMI Z-score did not have a modifier effect. And so subjects with OSA, they also had increased size in pharyngeal fat pads and abdominal visceral fat, but interestingly, that didn't correlate with the severity of OSA. So looking a little bit more into the demographics, they looked at all of these different metrics. They also took a PSG and looked at the different sleep parameters. And you can see the ones that are significant in the OSA versus the control subjects is AHI, SpO2 nadir, and arousal index. And then when they looked at the correlation coefficients, the oropharynx and all of the lymphoid tissues did have a correlation with AHI, but you can see that they didn't really have that correlation with BMI. And then interestingly, the tongue and the mandible was correlated with BMI, but it was not correlated with AHI. And so there were a couple of takeaway points from this study. The first was that the larger size of lymphoid tissues in obese children, which was not offset by other soft tissue volumes, could have explained the reduction in oropharyngeal size compared to the control subjects. The velopharynx, or this like oropharyngeal airway, it's thought to be like an overlap region for children because it's where the lower portion of their adenoids and the upper portion of their tonsils overlap. And so they think that mechanistically that might be why the OSA actually occurs, and it might be an independent factor from obesity. Second, they were saying that the lymphoid tissues significantly correlate with the severity of OSA. And so they kind of postulate that this could be one of the reasons why it's linked to conditions like local or systemic inflammation. And it could contribute to obesity and to OSA in non-obese children as well. And then lastly, interestingly, the soft palate, tongue, and mandible didn't differ in size between groups or correlate with OSA severity, but the tongue and mandible did correlate with BMI score. And so they thought that these tissues may not contribute to OSA in obese children the way that it has been reported in adults. And so these tissues develop as risk factors later in life, not necessarily in school-age children. And so overall, they kind of concluded that upper airway lymphoid hypertrophy is significant in obese children. There was kind of a surprisingly lackluster correlation between size and obesity, which was surprising to them. And then that last study, it kind of overlapped between mechanism and correlation, but then I found two studies that specifically looked at correlation, and they actually ended up having two like slightly different findings. The first one was a study by Su. This was a Chinese study. It was done where they looked at about 1,000 children, about 500 of them being obese and about 500 of them being normal weight. And in school children with obesity, they were found to have a higher AHI than those without, but there was no significant difference in preschool age children. And meaning that if you were obese, you were more likely to have OSA if you were school age than if you were preschool aged. And then they used logistical regression models to confirm the main risk factors in these children. And they found that in preschool age children, tonsillar hypertrophy and recurrent respiratory infections were the most were the factors that had most correlation with OSA. Whereas in school children, the main risk factors were parental snoring and obesity, which were two very different sort of ideas. And so in preschool age children, they think that maybe the rapidly developing size of tonsils and adenoids predispose them to having like respiratory infections, inflammation, enlargement, and that's where the OSA kind of roots from in that age group. Furthermore, there was a kind of an association between BMI and Mullen-Potty scores in both preschool and school-age children. And so they kind of concluded that Mullen-Potty can reflect the true volume of the pharyngeal cavity. It's an accurate sort of reflection. They also found that nocturnal enuresis and hyperactivity during the daytime were important risk factors for OSA across the board. So those are really important things to kind of talk about when you're taking like a pediatric history. And so overall, they kind of concluded that there may be differential risk factors for OSA in obese children, and there's maybe a different mechanism at play according to age, preschool versus school age. And then moving on to zoo, this was an interesting study that was done. There were 99 children and 99 control subjects. And they essentially looked at very similar parameters as the previous study. And what they found was that the prevalence of OSA was significantly higher in obese children with or without adenotonsillar hypertrophy than their non-obese counterparts. Obesity, hypertrophy, they were independent risk factors, and there was a positive correlation between obesity, AHI, and an inverse correlation between obesity and SpO2 nadir. And so while this first study with Sue found that there was this correlation with school-age children, Zoo actually found that there was a correlation among all of the children that were studied. And so for the most part, that correlation has been well established, but there are some studies that, there are some studies that have slightly differing findings. And you can kind of see in these graphs for Zoo, they kind of look at BMI scores versus like the SpO2 nadir, and you can see that correlation, like these two clusters here. And then I wanted to look at treatment options. There's really not a ton of data, but we recommend weight loss, we recommend TNAs, we recommend CPAP, and I kind of wanted to delineate, which of those is really the most evidence-based. And so there were really not very many studies that I found, but in this first study with Anderson, this was interesting. They investigated OSA using a type 3 portable device, a Nox T3, which is actually not validated in children, but they looked at children and adolescents aged 7 to 18 years with obesity who were enrolled in a chronic obesity treatment clinic that was outpatient. And they looked at follow-up appointments at 6 and 12 months, and they looked at different like anthropometric measures. What they found was they had 62 children, and there were a total of 55 children who attended the first follow-up, and then 29 children who had residual OSA who attended the second follow-up at 6 and 12 months. And essentially what they found was by the end of the study, the AHI had normalized through weight loss for 27 out of 62 children, so about 44% of them. And they used a regression analysis and found the decrease was associated, the decrease in BMI was associated with the decrease in AHI. And so overall, they kind of concluded that after about 6 months of treatment, if you have a significant decrease in BMI, you will most likely have a decrease in AHI and potentially even resolve your sleep apnea. And so it should be considered among the first line treatments for children and adolescents with OSA.
Shanta, in this patients, do you know what their like BMI like Z scores, like how much they changed? Like do they go from 99 90?
Let me see 1 second.
I think always the hardest part is like they ask like how much like
I know, like how much do you need to lose to actually see that effect? I know exactly. I wrote that down and I don't have it here. I'm sorry, but I have the paper saved, so I will just look at it again and see. Because I was thinking the same thing as I was presenting it. And I was like, wait a minute, how much weight did these kids actually lose? But no, that's a good question. But I'll look into it and find out for you. Okay, and then really the only other study I could find on treatment of OSA in these kids was this study here looking into TNAs. This was a huge study. It was a meta-analysis on post-operative changes before and after TNA, tonsillectomy, adenoidectomy, in obese and non-obese children. So in this study, they looked at 51 studies. There were about 3,000 subjects that were enrolled, and they looked at sleep architecture, AHI, and all of like basically the PSG parameters. And what they found was the overall success rate was 51% post-operatively for all children, obese and non-obese. But interestingly, they found that there was quite a disparity between success rates in obese children and non-obese children, meaning the success rate was about 34% in obese children, and it was 49% in non-obese children. And by success rate, I mean an AHI of less than 1. And then they also looked at AHI of less than 5 and consider that like a different definition of success. And for that, they found that 61% of obese children had a success rate versus about 84% of non-obese children. And so they did this forest plot, and you can kind of see like decrease and increase before and after the operation. And for AHI, you can see in non-obese children that that improvement was more significant. And then in terms of SaO2, you can see that their increase was more significant for non-obese children as well. So that disparity is kind of evident there. And so the conclusion here was that weight loss management could be a key in the treatment of obesity. Obesity-related OSA in children, especially in those who have had previous adenotonsillectomy surgery without clinical results. And so when we're kind of counseling patients, it could be, reasonable to mention, while your child could have this adenotonsillectomy, their risk of residual OSA is quite a bit higher if they kind of continue to be this weight, essentially, and kind of like tie in weight loss as a kind of another measure there. And so that kind of leads me to like, what should we do differently? Like, did anything I learned really change my practice? I don't think anything that I saw was really that groundbreaking. It was kind of things that we kind of could have assumed, but I didn't know that there was actually studies that backed it up. There was one piece of data that I saw from one study that was said that there was a positive predictive value of 65% from history taking alone, which is not great, but it's still very important to do. And specific questions that we should ask patients who are obese, again, are like nocturnal enuresis, hyperactivity, parental snoring, family history was a really strong factor there. And also hyperextension of the neck and prone sleep were more associated with children who are obese and having OSA. And so those are kind of just like more specific things to hone in on. There are several screening tools that exist actually. There's been a surprising amount of studies on those to look at if those can be validated or what kind of success rate they have, and they're really not very good at all. If you have like a standardized questionnaire, like does this patient snore, this, and this, it's really not very good at determining if children will have sleep apnea. In terms of physical exam, there's really not a ton of data that says, you should do this part of the exam versus others. But an oropharyngeal exam is kind of agreed upon to be extremely beneficial, which can be difficult in like the age of telemedicine. But there were some studies I saw that showed that if children who have OSA who have higher Mallampati scores, it is warranted to kind of use that tongue depressor, go in, get a look at those tonsils, look at the hard palate, look to see if there's any like risk factors for crowded airway, because there is a correlation between that as well. And then there's some really interesting studies going on between like upper airway imaging, DICE, biomarkers even, to see if there's any sort of correlation between those things and OSA. What they've essentially concluded is that those are very, very far from being usable or like, kind of contributing to our clinical management. And so the gold standard is still very much PSG. A couple of the studies that I kind of looked at that I didn't include here used what this is called, I think it's called a Metabite, and it's kind of a home sleep apnea test. There are a lot of there's a lot of work being done right now to hopefully get these home studies validated for children. That would kind of like make our management a lot easier. But as of, I think, 2017, the AASM said that they're still not validated because children are more likely to have milder versions of OSA, and these home studies are really not very good at picking it up. And so you might end up having a lot of children who have misdiagnoses. But they're working on it. My assumption is that it might start to be validated in kind of like a stepwise fashion, meaning like they include more adolescents, teenagers, and then get younger and younger as technology kind of improves. Oops. Okay. So, just some take-home points that I had. There could be a different mechanism between OSA between preschool and school-age children. Again, it's thought that this is due to kind of the oropharyngeal anatomy and the size, the ratio of like lymphoid tissue versus airway space. That was something I wasn't really I wasn't I didn't really know before doing this study. I know that, in ages 3 to 5, that's when they have the highest prevalence of having the tonsils kind of contribute, but um, there was actually a study validating that. And then again, most literature, it does correlate obesity with pediatric OSA. By and large, I probably looked at before 5 studies, and for the most part, they did find that correlation. And there's a higher risk of residual OSA following TNA in patients who have obesity. And so I wanted everyone to kind of bear with me here. This is my pediatrician side coming out. But as I was doing this study or this presentation, I actually saw that there were new treatment guidelines that came out from the AAP just 2 months ago, I think, February 2023. It was like a 100-page document. I've never really seen a guideline be that long. And it was essentially outlining how to address pediatric OSA, risk factors, just the whole 9 yards. And I kind of wanted to highlight this first table here. I know this is like out of the scope of sleep medicine, but I still thought it was really interesting. This first table here, this just kind of briefly outlines, kind of hard to see, I can't really see, different factors that contribute to obesity in children. And you can see it's just this kind of like endless list, access issues, community factors, family, environmental, individual, and they include like medical problems, ACEs, adverse childhood events, all kinds of things. This is a really, really complex and sort of delicate topic that I found can be kind of difficult to talk about with patients. There were some recommendations which we don't have to go over, but treatment is really this like multifaceted approach, right? There were 2 schematics that they had that I thought were really nice that kind of show the complexity of this issue. There's fitness, functioning, friends, family, and fun, and all of these kind of have to be addressed in order to kind of have pediatric weight loss or weight maintenance be successful. And then they had a different schematic that kind of address different parts of lifestyle treatment. And you can just see there's just so many things that are involved. So this is a really difficult topic to kind of address. I notice in clinic, oftentimes because resources are so limited, sometimes it feels like a bit of a write-off to just ask for like a nutrition referral and just kind of let that end wherever it does. But when you really have data that says that that's kind of the first line treatment that you should be looking at for a lot of these kids, versus like surgical options and CPAP, even though I wasn't able to find very many studies on CPAP. And so that's just my little soapbox there. And I guess the question I just wanted to pose to everyone was, how can sleep providers be better advocates for their patients, who are pediatric and are obese? Is there a role that we play? Is this kind of outside of our scope? Is it just like too much to do in one visit? Is it just too overwhelming? Are we not comfortable doing it? Just kind of wanted to get people's thoughts on the matter. Did I say anything new? I don't know.
I think this is like a really hard topic. I mean, I think I remember hearing from Maida that I think that our clinic, or the sleep clinic at Seattle Children's, has like the highest BMI average than any other clinic in at Seattle Children's, even including like the endocrinology clinic,
Oh
which
my gosh.
is surprising to me. Um, so I think that's something that we definitely have to be more cognizant about, and just knowing the resources that we have.
Yeah.
And I agree that nutrition is a huge portion
Hmm.
of it. And I think the hard part that I find sometimes have is like, how do we find also nutrition that is culturally sensitive as well?
Right.
Because I think a lot of our patients may not have the same type of um, dietary cultural dietary things that maybe the nutrition that we have here. So that's why I always try to, I think we saw maybe I don't remember it was you was seeing a patient who came from Yakima and had
Hmm.
whole like Mexican heritage, and
Hmm.
referring to a nutritionist from that clinic that would probably be able to have more sensitive um, dietary plans for that family.
Hmm. Yeah. No, I noticed that when I do see obese patients in peds clinic, it's exceedingly rare that the parents will not also be obese. And so it's just this, how can you kind of address that for this one patient who kind of relies on, you know, their food and their diet being from their parents who also struggle. You know what I mean? And it's just it's really, I don't know, sometimes I just want to throw my hands up, um but it's interesting.
Jeremy, how do you, I don't remember at Children's, it's been a long time, so I don't remember when we were over there. Is there kind of a multidisciplinary aspect to the sleep clinic with dietitian, things like that,
Yeah, I mean,
readily available? How does that work at Seattle Children's?
yeah, I mean, I wish we did. I think that we
Mhm.
don't, unfortunately. I mean, I recently referred a child, a teenager that had a BMI of like 50 to into like our insulin resistance clinic, and I think which has, I think, an endocrinologist, a dietitian, and maybe physical therapy as well. And I mean, their wait lists are just a year
Mhm.
too long, and it's just so hard to like I mean, we do have the resources, but I think that we just are. It's such a big epidemic, as Shanta was saying. 50% of our kids are obese. That it's trying to hard to find how do we best get these resources to these kids.
Mm.
Yeah, and I guess the other parallel I would wonder about, so like at the VA for adults, we have what's called the MOVE program, right? Which is in and of itself is a multidisciplinary kind of course, so to speak, that patients attend that gives instruction and education on activity, diet, et cetera. Is there anything combined like that in a pediatric world? Does it work? Maybe it doesn't work in a pediatric
Mhm.
universe. Shanta, you may know more about this than I because you're closer to pediatric residents.
Yeah.
But there are like YMCA programs that
Mhm.
have tried to like pair community resources with the YMCA to help kids with like nutrition and
Yeah.
movement.
Yeah. There in Cleveland, I noticed that this is we had a talk from a population health doc, and a lot of those kind of like multidisciplinary programs are more prevalent in at like hospital institutions that are like community or county hospitals, just because it's like a higher risk of these of prevalence for these things. And so at Metro in Cleveland, we had what was called like the new clinic, which was like nutrition, exercise, and wellness. And there was like I remember it was like infamous for having like a high no-show rate, but when people did show up, it was actually incorporated that a nutritionist would like make a house call, to kind of look at folks' kitchens and like actually see like, what foods were available, kind of reducing processed foods, getting more shopping on the outside of the grocery store is what they would always say. And those tended to be the more successful programs, people who actually like went out into the community and like made those changes for them. But that's a really like laborious, that requires a lot of resources. And it's just it's a problem that's growing faster than the solutions, it seems, in a way. So
No, was a great topic, and yes, in some areas of the country is horrible. And I just wanted you to, besides the individual hospital of resources, creating more clinics to address this, or a multidisciplinary part of a clinic, pediatrics clinics with such a large population of obesity clinics should have something to address that aspect, because just by telling them use a CPAP or just send them into ENT, you're missing a
mm,
large population of patients that you will not be able to treat. So you
mm-hmm,
know that. So
mm-hmm,
so that will be a call for multidisciplinary treatment, including obesity management as part of the clinic.
yeah,
I did have a patient many years ago, kid that was morbidly obese. I think it was like 300, 400 pounds. And it was like, not even a middle schooler, so it was horrible. And that call, we ended up having a call into the ethics committee, because obviously a kid that was less
Mm.
than 10 years old could not by himself eat those calories without being a house issue. Because he was not mobile, he couldn't go. He was so obese,
Oh
he
my
couldn't
gosh.
handle it. So, so that kind of got me into this ethics of this, and I cannot. There are very interesting issues about the ethics of childhood obesity, and how much is responsibility of the child. Of course, will depend a lot of the age. How much is responsibility of the
Hmm.
parents, which are providing care? How much is responsibility of the environment, our society, the cultural views of what you eat? How much is responsibility of the society, because we don't provide adequate vegetables in areas that don't have high income, for example, or what
Hmm.
kind of fast food we provide, or what the schools provide for the children. So, and then you can go into other things that, for example, like the right of a kid to be healthy, raised in a healthy environment. It's a right, it's a human right, but it's not prevail. And then you go into more the bigger pictures, politics, like why do I allow
Right.
advertising of fat food, non-healthy kids directly to the kids? And you keep going on all these circles. And obviously there are failures in the system all over. And should we allow that industry directly advertise kids to eat this high calorie things that are not healthy at all, right?
Hmm.
And the kid may not have the ability to make a decision, right? Because he's too young. So there's like all these ethical things
Yeah.
that, as a sleep specialist and seeing kids that are affected that do not have the ability to have an advocate, or for even an advocate for the parents, make the parents understand that
Hmm.
not is just like the first mother that you say, "Why do you tell me that?" Or how guilty they feel about
Hmm.
when they cannot buy food that is not in their budget. Make them understand there is a system problem, and things like that. And I cannot. There were a lot of publications or that. I just look at an article that was very old, but it kind of talks about those things of the ethics. But there are multiple other publications related to the ethics of childhood obesity, which is, I think, is fascinating, and requires all of us to
Hmm.
support, not just say, oh yeah, you should lose weight, but support all those systemic things that are not favoring a kid to be raised in a healthy environment.
Hmm.
So, Shanta, I thought you did a great job of having that case right at the beginning that kind of showed how
Hmm.
this can clinically manifest, right?
Yeah.
But I'm curious, after you preparing this and going through this, would you engage that parent differently? What did you, how do you, and you don't always know when you're stepping
Yeah.
on a landmine in those situations, right?
Yeah.
But
Yeah.
I'm curious, do you think you would do anything differently? Or, so that's part one. And then part two, if you ended up in that same landmine, how would you now navigate your way out of it?
Yeah, no, it's a good question. I kind of summarized that slide, for brevity, but I would hope that a provider didn't just say, "Oh, you have OSA, let's jump into this nutrition referral," right, without having to kind of explain the background of things. But it has happened. It's a very sensitive topic and it's very delicate to kind of approach with parents. Like Dr. Constance was saying, a lot of times these foods are not within their budget. They live in food deserts, and I think a lot of folks in that community, when like the whole ethical argument comes into play, it can feel really punitive to them, and they can feel like they are averse to coming in for help. And so I would deal with them very gently, with my pediatrician gloves. I would say, I understand that there's kind of like a systemic failure kind of going on that's kind of resulted in this situation, but I would address it. I don't really shy away from those types of conversations, but I find that if I do my best to make sure that the patient and the parent are leaving on better terms with me, I have a better chance of success with them. So that's kind of the approach that I take.
Yeah, I wonder, I mean, I've found myself over the years with adult patients, sometimes I can kind of preempt what I think is going to happen, and sometimes I step
Exactly.
into it and work my way out of it. But one thing I I do that. Sometimes I think helps is I say, look, I know, because they're getting, as this adult verbalized, right? They're getting told obesity is the only cause of all their problems, and
Right.
that's just exhausting, right?
Yeah,
So
it
sometimes
is.
I break that down to patients and I say, look, I know I don't want to be that guy that's telling you if only you lose weight, this will all go away, because in sleep apnea, I can't promise you that, right?
Yeah,
What I
exactly.
can, and I think that starts to kind of win patients over sometimes, as you say, but what I can tell you is, you know,
Hmm.
30% of people have improvements. And,
Hmm.
for some people, anecdotally, I've seen this work such much they'd come off CPAP, but,
Hmm.
I can't promise you that.
Right.
That's on an adult level. Does that work with parents and kids, or is that fodder?
They might get more mad if you say that, to be honest. Like, I think the approach that I take with pediatric obesity is, like, especially if a child's younger, like 3 or 4 years old, and they come in and they're like 100 pounds, which happens sometimes. I'll say, we never really want children to lose weight. We want them to maintain their weight as they grow, and I feel like that is a little bit of an easier thing
Interesting.
to
Yeah.
grasp, because you don't really want like a 4-year-old like losing 20, 30 pounds or something like that. You just want them to kind of maintain it as their length grows and they kind of stretch out and fill out, and that's a little bit, I feel like that's my best in for those families. They tend to like that more.
I also, maybe this is also me being a little bit more like reserved, but sometimes I always like to mention not talk about weight, just because there's a lot of, especially, I
Hmm.
mean, even with adult care, there's a lot of stigma with weight. But I always am worried about how much emphasis we place on pediatrics, especially because of like the growing risk of anorexia and bulimia,
Hmm.
orthorexia, that we see a lot of these kids get it from all sides, and it really can increase their shame, the embarrassment that they
Hmm.
have, and affect their mental health. So I'm always really careful about how I word what I say, and talk more about
Hmm.
not weight loss, but also just like keeping your body moving and healthy.
Yeah.
Just because I mean, I've had parents that have told me beforehand, like, please don't mention like
Hmm.
weight. It's a super sensitive issue, which
Hmm.
is understandable.
Yeah, no, for sure. I've taken parents into different rooms, because I really try to avoid using the words weight or like even BMI, because it's kind of like medical jargon. I avoid saying those words, and kind of go more towards like lifestyle, like movement, activity, that sort of thing, like you were saying, especially in front of the child, because like there are so many times. I mean, it's well known that sometimes there are things that are triggering during a doctor's visit that kind of precipitates children having these sort of like eating disorders as a result of the conversations we have with them, because they're done kind of so poorly with very little bedside manner. And that's always been a fear for me too, but they are things that have to be addressed, unfortunately. So
Yeah, it's an interesting difference to hear, Jeremy.
mhm.
I mean, in the adult world, especially on the VA side, I mean, there was at one point kind of almost a mandate that every patient with OSA had to have counseling about obesity,
Oh.
um, which was even at one point was proposed as being a pay for performance metric that physicians' pay would be based on. So just kind of shows.
Mhm.
Yeah. So we are seeing more patients also in the adult population with eating disorders, which also you should not address those issues. And
Mhm.
sometimes it's clearly flagged in the chart, sometimes it's not, which is very sad because you can trigger significant backlash by doing that.
Yeah.
And so the other thing is, like, as a physicians, we don't receive a lot of information or training in eating disorders or treatment or things. So it's also
Mhm.
like a lot of the time patients go to a sleep clinic, which have patients come in, it's like, and could have been adequately treated with the CPAP, but it was such a traumatic experience being told that they were fat or something when they were seeing that they should lose weight, that they just for 10 years or 20 years don't pursue any other treatment. So we have to be very careful what to say or what impression we make on those patients, because they could have been treated with CPAP, for example, in the meantime, and they're just become averse to any medical treatment because they get hurt.
Mhm.
The other thing that will be interesting is that we don't know yet is that what is going to happen with those kids that have childhood obesity and
Mhm.
untreated apnea. What is going
Mhm.
to happen? Is that going to increase their cardiovascular risk, decrease their lifespan or something when
Yeah.
they're adults? And who knows how many years it's going to take until we figure out an answer, but it's going to be interesting to know.
Yeah, I wish I had that answer because I get a lot of questions about that.
Yeah.
That's right. Yeah. So the parents want to know, which is very understandable. Is my kid that has residual sleep apnea going to have consequences? And we don't know what to tell them, and we don't know how aggressive to be, right?
Mm-hmm.
And
You
especially because our categories of severe and moderate are different than the categories for adults. We have to use, do we use the same like categories for like that long-term treatment? Because I say we think of adults with severe sleep apnea having all those long-term risk factors, but for children, severe is more than 10, not more than 30. So it's interesting.
Yeah. So I have that. Sometimes I get patients that are teenagers and they're graduating and they come and they come and they have an HI of 9. And I was like, well, if you ask me for long-term consequences, it's going to be totally different, right?
Yeah.
What are you going to advise that speed? And it's very hard sometimes. Yeah.
Yeah. Ifoma, did you have something to add?
Yeah. I thought this topic was a really great one, actually. It made my heart tingle a little bit just to hear you talk about it. For several reasons. I think one, the question you asked about how can we be better advocates, I think we're really missing out in advocating for our patients by not diving head on into this. And one of the reasons I think that is I went down this rabbit hole recently about what exactly is the cause of obstructive sleep apnea and how did we get here. And one of the information I'm coming across is, some of the tissues that's been dissected, there's like evidence of inflammation, edema going on around that area, as a possible like early signs of dysfunction, just like local dysfunction that's occurring there. And then that kind of took me down the rabbit hole of what exactly is causing this. This is in patients that are just snoring and in patients that have obstructive sleep apnea. And that raised another question for me: is sleep apnea not necessarily a localized disease? And this is a way of our body, actually, the easiest way of our body to let us know that there's systemic inflammation going on by the snoring sound. So, and the reason why, it ties into your study is me going down that rabbit hole. I came across this whole idea of lymphatic dysfunction, which is associated with high fat diet. And there's been a lot of publications recently about, high fat diet consumption, lymphatic dysfunction as a tie into obesity. So if there's this pathway that really takes us back to, poor diet, which takes us back to socioeconomic disparity, ethnic disparity. I think for me, at least based on the little reading that I've done so far, I think there really is an opportunity for us to learn more about, nutrition and its association with these form of systemic inflammation and possibly tie to obstructive sleep apnea, and maybe advocate a little bit more about what changes we need to see in our community, because like you said, it becomes very difficult to counsel someone about dietary change if they live in a food desert. It's very difficult to counsel someone about changing their diet if they have to work 3 jobs to put food on your table. So I feel like there is an opportunity for us to maybe advocate more, but that begins with us actually learning a little bit more about nutrition, which, like Dr. Constance says, we don't get educated about it. So it makes it very difficult to counsel patient on that. So my takeaway from your talk is we need to learn more about nutrition. It would be really nice if there's a multidisciplinary approach where if we are not the ones that have that nutrition information, then maybe collaborating with nutritionists and actually prioritize them being part of patient care. But my focus is not necessarily on obesity, is more so on that systemic inflammation that in some patients actually manifests as obesity, but that's not necessarily the issue. The issue is what's happening downstream in a cellular level. So I thought it was really cool. It was nice to see the presentation.
Just speaking of that quickly, there was one study I saw that was like kind of a one-off and had a small sample size, but it was done in 2016, and they looked at like IL-17 and IL-23 in children with OSA, like, you know, as like inflammatory biomarkers. And there are a couple studies that like associated with you know, with elevation associated with OSA. So I think that that's becoming kind of a hot topic as well. There's just not a lot yet, so. But thank you for that. Thanks, everybody. I finished a little early. Sorry. I thought it was going to take me way longer than that, but all right.
Great job. Thanks.
Thank you.
Great job.
Bye.
Bye, everyone.